So now we're going to talk about infant of a diabetic mother. This starts on page 682. What we want to understand is this is a infant who is born to a mother who was gestational diabetic, or she also maybe had type 2 or type 1 diabetes. They put them under the same class because the same potential risk as far as newborn risk are the same. So what is the single most important factor that influences fetal well-being? Well, this is the overall glucose status of mom. How well did she control her sugars? How, was it diet controlled, medicine, or was she non-compliant and her sugars were all over the place? So elevated levels of glycohemoglobin during preconception appears to be associated with a higher incidence of congenital malformations. A lot of times these babies who are born to a diabetic mother, they are macrosomic, and that is the little baby that you're looking at right now. We want to monitor their glucose levels. We want to keep their glucose level above 45. That's the magic number for newborns. If the baby is symptomatic and we check the sugar and the sugar is less than 40, they are going to receive some kind of treatment. We usually encourage mom to breastfeed, or if mom's not breastfeeding, she's going to formula feed within the first hour of life for babies who maybe are at higher risk of having hypoglycemia. They have something that's called sucrose or sugar water. We try to discourage from babies getting sugar water in the very beginning because they're going to have that initial rise in their glucose but then probably bottom out later. So we want more of a steady stream. So that's why we would encourage breastfeeding and formula feeding within the first hour. A lot of times these macrosomic babies, they're disproportioned. They have large abdominal circumference, larger shoulders, so this puts them at higher risk for shoulder dystocia or a birth injury. They're a lot of times the ones that are also at higher risk for the fractured clavicle. We have talked about, it's probably been a while, when mom's pregnant, placenta is the one that is responsible for doing all the transferring. Glucose travels across the placenta, however the insulin does not. So when baby is born and we cut the cord and remove baby from the placenta, we have this continued production of insulin. This starts to deplete, creating a hyperinsulin state. Then that's where you see the hypoglycemic or hypoglycemia effect happen, typically within a half an hour to 4 hours of life. You always see this. This is a higher risk if mom is poorly controlled herself. What happens if baby's blood sugars continue to drop and get critically low? They have the potential of neurological damage or death. Babies born to moms who have advanced diabetes may not always be a large for gestational age. They may actually be a small for gestational age or have IUGR. And this is usually due to the maternal vascular placental actual involvement. So just a few things. We're still talking about infants of diabetic mothers, which are IDM. We need to know that they're an increased risk for congenital anomalies. They're also susceptible to hypoglycemia, hypocalcemia, hypomagnesemia, polycythemia, hyperbilirubinemia. Ooh, that's a mouthful. Cardiomyopathy and respiratory distress syndrome. Cardiac anomalies may also be present. The reason that these babies are at a high risk for respiratory distress syndrome, which we'll talk about in a few minutes, is because they have that hyperinsulin and hyperglycemic effect in the mother. She's in that state. This reduces the surfactant synthesis, which ends up putting that newborn at a higher risk for respiratory distress syndrome. So on box 25-3, page 682, there's some clinical manifestations of infants of diabetic mothers. Usually there's some type of a protocol for who's at high risk and who would receive blood sugar checks. And when I'm talking about who, I'm talking about the infant. There's usually some kind of protocol based on the facility of how often it should be checked. What would you do if it's less than 40 or greater than 45? So there's usually some type of protocol. Your textbook says that it is recommended that blood glucose is checked for the first 2 to 4 days of life.